Hello everyone, welcome back to our channel. In today's video, we will be discussing heart failure. It is a very common and serious cardiovascular condition that every clinician should master. Here's the definition. Heart failure is a complex clinical syndrome due to structural or functional cardiac disorder that impairs the ability of ventricle to eject blood or fill itself with blood. So by definition, you can see it can be an structural or functional cause, and the issue here might be a pumping issue or might be a filling issue. And then the classification of heart failure. It is based on the ejection fraction, and at first here you can see the heart failure with reduced ejection fraction, that is ejection fraction below 40, and then preserved ejection fraction. Here the ejection fraction is above 50 and the at last mildly reduced ejection fraction. Here you can see the ejection fraction is in between these two, that is 41 to 50 percentage, that is 41 to 49 percentage. And here you can see the NIHA classification, that is New York Heart Association classification. It is commonly used in case of dyspnea, but it can be also used for angina and palpitation. But you should remember, it is never used in syncope. And you can learn this by remembering. At first it compares the symptoms with activity and then the limitation of activity. At first, symptoms occurs in more than ordinary physical activity, and then at ordinary physical activity, and then less than ordinary, and at last class 4 is symptoms even at rest, and then limitation of activity. At first no limitation, then slight limitation, and class 3 is marked limitation, and class 4 is severe limitation. And here we see the etiology. The etiology can be remembered by the mnemonic CHIPS. And at first, C for coronary artery disease, and it is one of the most common cause. And hypertension, it is also an important cause of heart failure. And then infiltrative diseases like amyloidosis, and P for primary cardiomyopathies. I will try to discuss cardiomyopathies in a separate video. And then S for structural heart diseases like valvular heart diseases that may lead to heart failure. And these are the other causes such as myocarditis, arrhythmias, and pericardial diseases. And then the important thing, pathophysiology. Here you can see what is heart failure. It is just a demand and supply defect. That is, it is the imbalance between heart's ability to pump blood and body's demand for deoxygenated blood. So it's demand and supply. And then here you can see at first there is a primary insult to heart. That is, it might be an valvular heart disease or whatever. And this leads to decreased cardiac output. And the decreased cardiac output leads to activation of neurohormonal systems, and because of this activation there leads to hemodynamic changes, and because of all these there might be a ventricular remodeling and worsening of disease, and I will be discussing these all in details. And at first, neurohormonal systems. Here you can see the main thing is sympathetic nervous system. Here, activation of sympathetic nervous system increases the heart rate and contractibility, and also increases the vasoconstriction. And then renin angiotensin aldosterone system, RAS system. Here, activation of renin leads to angiotensin 2 activation, and the action of angiotensin 2 is vasoconstriction and aldosterone release. And aldosterone, it's an important mineralocorticoid. It, it helps in sodium and water retention, and because of this the volume overload occurs and results in afterload increase. And then arginine vasopressin, that is another name for antidiuretic hormone. Here you can see antidiuretic, so it prevents diuresis and promotes water reabsorption and vasoconstriction. It also results in plasma volume overload. And then natriuretic peptides, atrial and brain, and it is released as due to increased wall stress by increased volume, and it has a protective effect, and it results in natriuresis, that is and then vasodilation and inhibition of RAS and SNS, so that it will be protective. And then the hemodynamic changes which happens because of neurohormonal changes. Here you can see increase in preload, it's because there is increase in the volume, and then afterload increases, it's because of vasoconstriction, and contractility decreases, and stroke volume decreases, and end diastolic volume increases. These three are because of heart failure, these three decreases, and end diastolic volume increases, and these results in remodeling of the ventricular muscle, and it is because chronic stress, neurohormonal activation, and volume overload. These leads to myocyte hypertrophy, myocyte apoptosis, and fibrosis, and results in change in ventricular shape and size, and at last there will be progressive worsening of the condition. And here we see the clinical features. You can learn this by learning the mechanism. At first, the systolic left ventricular failure. This results in forward symptoms due to decreased output, such as extreme fatigue, altered mentation, dyspnea, oliguria, cold extremities, and signs such as narrow pulse pressure, pulses alternance, and that hot sound, and cardiomegaly. And then diastolic failure. At first we see left ventricular failure, so it results in the increase in the end diastolic pressure. This results in increase in left atrial pressure and leads to increased pulmonary capillary venous pressure, so that backward symptoms you can see this. And then the symptoms are dyspnea, nocturnal cough, acute pulmonary edema, orthopnea, paroxysmal nocturnal dyspnea, and third heart sound. And then right ventricular diastolic failure. This results in filling defect, so that it causes ascites, edema, hepatomegaly, increase in the jugular venous pressure, and volume overload states, as filling from inferior vena cava and superior vena cava is affected. And then Framingham criteria. It is a classic one that is widely used clinically and exam based. So you can read this and memorize this. And here are some of the precipitating factors and the factors which increases the severity. At first, non-compliance of drugs and excessive fluid intake in renal failure, infection, anemia, atrial fibrillation, myocardial ischemia, worsening of hypertension. And then the diagnosis. Here you can see echocardiography. It helps in assessing of ejection fraction and any kind of structural abnormalities. And then ECG. It helps to detect arrhythmias and ischemia of heart muscles. And then chest X-ray helps in finding pulmonary congestion and cardiomegaly. And then the levels of natriuretic peptides. It's elevated in heart failure, as we saw in the pathophysiology. And then staging. The staging is divided into A, B, C, D, 4 stages. At first A, here only the risk of heart failure is present and no symptoms and no structural disease. And then the stage B, here there is structural heart disease but no symptoms. And stage C, it is structural heart disease plus symptoms. And at last, stage D, refractive heart failure. And at last, management. Here you can see the pharmacological management for heart failure with reduced ejection fraction. And these are the key pillars, that is the four main drugs used in heart failure. These are angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and neprilysin inhibitor, that is sacubitril and valsartan combination. And then beta blockers, these are mostly the cardioselective beta blockers like bisoprolol, carvedilol, and metoprolol succinate. And then mineralocorticoid receptor antagonist MRI, such as spironolactone and eplerenone. And then SGLT2 inhibitor. And then the additional therapies such as loop diuretics, ivabradine, and hydralazine plus isosorbide dinitrate combination can be used. And here we see this is the neurohormonal systems that results as a compensatory mechanism, and the drugs which I mentioned, beta blockers, which blocks the sympathetic nervous system, and mineralocorticoid receptor antagonist, it blocks the RAS, renin angiotensin aldosterone system, and ACE inhibitors or ARNI, it also blocks the RAS. And the actions of other drugs such as SGLT2 inhibitors, it results in diuresis and natriuresis, and because of these the preload decreases, so that LV wall stress is also decreased. And it has also other actions such as decrease in afterload, and then direct effects on the myocardial energetics, and then loop diuretics causes diuresis, so that it is used to relieve symptoms from congestion, edema, and pulmonary symptoms. And then hydralazine and isosorbide dinitrate, it is a vasodilator, so decreases the afterload. And ivabradine, you can see it is an inhibitor of funny current in SA node, and it is used only in the heart rate if more than 70, as it decreases the heart rate. And then digoxin, it is used in selected symptomatic patient despite optimal therapy. And then the management of heart failure with preserved ejection fraction, and here the mortality benefits are less and not yet proved. And here the main management is by maintaining the symptoms and by maintaining the managing the comorbidities like hypertension, diabetes, obesity, etc. And then in case of advanced heart failure, we can use implantable cardioverter defibrillators, cardio resynchronization therapy, left ventricular assist device, and even heart transplantation can be helpful. And then the prognosis. Here we see the prognosis depends on the various factors such as the ejection fraction, New York Heart Association functional class, and natriuretic peptide levels, renal function, and response to therapy. And if you found this video helpful, do like, share, and subscribe for more such contents. And drop your questions and topic requests in comment section. Thank you for watching.